I will talk about the principle of open pilon fractures, choice of the soft tissue management, soft tissue reconstructions, fix and flap, or flap and delay fixation. The principle of the open pilon fractures, as we know, radical debridement. This is the key to success. Lead debridement usually is depend on the first injury and the experience of the surgeons. Antibiotics, both the systemic and the local. I say the local is very helpful in this situation. Then the stage wound management. After that, you make a temporary external fixation. And then after the wound is good condition, you change to definitive internal or retain the external fixation as a definitive treatment. Yeah. How about the recent literature? Yeah. In 2020, just last year, they mentioned about the definitive management of open pilon fractures with the fine wine fixation. That means this is the ring external fixator. It starts with the stage aggressive wound debridement, systemic and local antibiotics, and then external fixator. Maybe first with just the tubular external fixator, simple one, and then after you have time to plan, then you change to the spanning external fixator in the wide frame way. And there are so many cases that you can see. This is a very severe in the case report last year. Open tibia, the pilon fractures. And first start with the treatment by the external fixator, and you see the wound condition, and then change to the Ilislov frame with slightly shortening with the frame to treat the soft tissue and allow the soft tissue to heal, and then do the definitive lengthening of the bone and bone transportation. And this is from the case report. I think this is the very nice way another way to treat the open pilon fractures. And it's final healing with a good function. However, we know the disadvantage of the Ilislov, both the mechanical and the biological. You have the bulky frame, long duration of instabilities, breakage of the wire, and long learning curve. You have the pin-tag infection, chance of the neurovascular injury, pain, joint stiffness, and some osteolysis. Now, this is another one. Just 2 years ago, described the clinical and radiographic outcome of the open pilon fractures. But here, they use the open reduction and internal fixation in 2 stages in high-energy open pilon fractures. And the complication and the result can be good if you make an intensive debridement. Again, coming back with the debridement, antibiotics, bone graft, and post-op exercise, soft tissue management. Now, I show you the case I just showed 3 cases, which is the different way of treatment. It's almost like the same injury. You see, this is the open pilon fractures. Most of the wound is on the medial side because it's very thin skin. First, we start with the radical debridement. As we said, okay, some may say, okay, you try to fix the joint, but maybe not necessary if you have a good soft tissue care later. You can go in a few days, and then deduction of the joint may not be a difficult one. Now, what next? You have the wound on the medial side. Ilislov shortening, yes, another option. Vacuum dressing, this is a really long way and it's not work well. And the last one is the flap coverage. We can do the internal fixation. If you can do the flap, or the plastic surgeons, they are very friendly with you, then you can do a fixation. This is the medial and lateral column fixation. And now you have the defect with the soft tissue loss. Reconstruction. Yes, we can use the reverse flap from the posterior, and then you rotate to cover on your defect. And this 1 year result with a good outcome and the bone healing. You can make a bone graft at the first surgery at the time you do the internal fixation and fix. This we call the fix and flap. Another option, this is another case. The wound is on the medial side again. Debridement, external fixation. You see the fibula. Maybe we can do it or we can leave it, as Stefan mentioned. External fixator first, and then we close the bone gap, the soft tissue defect by using this reverse sural again. And now the wound is closed. We have the soft tissue, good soft tissue coverage of the bone. And then you see around here, you can do any internal fixation, even through this end of the flap. Then you can elevate because the stock is come from the back. And then, in this case, we make anterolateral. Yes, that's the second stage, delay internal fixation, and then the bone heal. This is another case, maybe not the pilon, but almost close to the pilon. This is the distal tibia angle fracture dislocation, and you see it's intra-articular fractures a little bit here, but this is a severe injury with the dislocation of the ankle joint. And this is the first surgery at the night. It was done by the external fixators, try to realign the fibula, but the ankle joint is still not in a good position. The next surgery, yes, this is the redebridement on the second day, and you see the large defect with the expose of the tendon, and also the fibula is here. So what next? Now is you have the time. You can realign the fibula. In this case, we realign the fibula to make anatomical position, and then try to reduce the joint, ankle joint stabilities added with the syndesmotic screw. Now the ankle look very anatomical, in anatomical shape, and now you have a little bit fixation with the surcrush on the medial, on the tibia, on the medial side, and I use the antibiotic beads to treat the local infection as well. This is the beads, gentamicin, vancomycin, and this is the final. The soft tissue defect cannot cause at the first time, but we should wait until the soft tissue is safe for the infection. And now the second step, this is no infection. We use the reverse sural flap again to cover the medial wound defect. And this is the skin graft after the flap and the skin graft. However, if you look carefully now, where you want to fix this tibia and the ankle, on the medial side here, you have the skin graft, you have the stop of this reverse sural flap. On the lateral, yes, you can go in, but this is another soft tissue problem. So another option, I use this LCP as external fixator. This is the pre-op planning. You can fix 5 screws in the distal fragment by using this as a, you can see I use this as spacer. I put the screw out in the screw hole and then use it as a spacer. And then this is the intraoperative. You will see, okay, this is the good position of the screw. Then you fix in the distal fragment and the proximal fragment here. And now this is the post-op. It's stable enough to allow the patient to move the ankle or even the weight bearing. Because now you reconstruction both medial and lateral column. This is 4 months. The tibia looks very nice and there is no infection and it looks like the bone going to heal. And this is the range of motion. Yeah, and I'm not sure the video works. You can see the patient can walk. Yeah, and sit down. At the 7 months, the bone healed. I removed the external fixator, and this is the final 7 months. The bone healed with a good ankle position, and this is the 1 year. Return to normal. Yeah, and this is the last function. He can run a little bit. He can jump. Reverse Euro flap, I think this is another good option. It's a versatile flap around the ankle, especially to treat these pilon fractures. If you have the experience, you can cover the area, large area, about 10 to 10 centimeters, and you can later elevate if necessary, in case you want to make a definitive internal fixation later. I said it's possible to perform as an orthoplastic. That means it's not a so difficult one that you cannot do it. Yeah. In my place, my colleagues and I, personally, I can do it. But if you have the plastic surgeons that you can do it and understand your condition, that will be a good option. So my take-home message, two-stage treatment is recommended in open tibial pilon fractures. It's no definitive protocol. It depends on the patient condition and your experience. Radical debridement is most important. Antibiotics with the local soft tissue coverage, 90%, you can use a reverse Euro flap. You can do fix and flap. You can do flap and then delay internal fixation, or you can make a flap and definitive use external fixation or the Ilisalov. Thank you very much.